Hello everyone, myself Dr. Manohar Kanwadia, intervention pain and spine physician. Today we are going to very sophisticated and very simple procedure for the disc prolapse, which is percutaneous transforaminal endoscopic decompression. First of all, we will understand the MRI and relevant clinical feature and the history of the patient, and after that we will start our procedure. So guys, this patient is 30-year-old Yasir patient and having the history of weightlifting in the gym. At the time of weightlifting, patient is having back pain which is radiating to the left lower leg, and when MRI get done, the finding of the MRI is in axial section we can see at L5S1 level there is a paracentral disc protrusion, we can say very clearly, and the disc prolapse or the fragment of the disc is reaching up to the foramen level also. So it's a single level disc prolapse, although it is L5S1 level, but I have decided to do with the transforaminal because the height of the iliac crest is just below to the pedicular line, so it is easy to do the transforaminal, so we opted for the transforaminal. In many patients, if there is L5S1 level disc prolapse, it is difficult to do with the transforaminal endoscopic discectomy because there are many factors. Few of them is the iliac crest is high at the and the aperture of the transforaminal foramen is smaller in compared to the above levels, and there is a large transverse process. So these are the factors due to which we feel difficulty while doing the transforaminal discectomy at the level of L5S1 level. Patient in prone position, this is cranial, this is caudal, and because we are standing on the left side, because the patient is having problem or the disc prolapse on the left side, and other things like camera, SIAM and our screen will be always will be opposite side for our convenience during the surgical procedure. First of all, most important thing is that everything in our operation theater we are coming in between our operation procedure should be sterile and covered with the sterile sheets or gown or any other material. This is SIAM covered with the sterile polythene sheet, and the patient is whole covered with the spine scrub. The camera cable and the light source cable is also covered with the sterile sheet. Our SIAM should be in a 3 AP view. 3 AP view means end plates of the related vertebra should be the parallel, and the distance between the spinous process and the pedicle should be the equal. So the most important thing to do a proper procedure, our SIAM should be in true AP view. Second, we will make a line at the spinous process. We are marking at the spinous process to measure the distance from the center or to measure the line from the midline. Now we will mark at the level of affected disc. So is at the level of L5S1. देखा भाई, देखा lateral out. So this is the marking of the line from anterior border of the disc to the parallel of the end plates. Now we can see there is a transection of the two lines, anterior and the lateral lines. This is the entry point of the needle. So there are various methods to determine the entry of our needle to start this procedure. So my method is, there is an intersection point between the line from the center of the disc and just above to the iliac crest, and in AP view, and in parallelly there is a line drawing from the anterior border of the disc and parallel to the vertebral bodies. So this is the intersecting point, and if we measure from the center or the midline, this is about 14 centimeters. So roughly the many authors said that it should be 8 to 12 centimeters from the midline, and or 9 to 11 centimeters from the midline, and some authors said that it should be between the spinous process line and the facet process line. So different surgeons have different methods of to mark the entry of the needle in this procedure. The entry of the needle is also depend on the height of the patient, weight of the patient, BMI, and the distance from the skin to the vertebral bodies. So I already marked the entry. Now we will proceed the procedure. As I told that this procedure is carried out in local anesthesia only. So this is the beauty of this procedure, that patient can see or the watch his or her procedure on the screen while the procedure going done or the surgery going done. And if there is if we are damaging or touching the neural structure, patient can tell or patient can communicate. So there the chances of the damage to the neural structure is very rare, or you can say very less. Just after the procedure, patient can walk, or a patient can go home. So this is the beauty of this procedure, and we will do this procedure in solely local anesthesia only. Sometimes if the patient is over apprehensive and anxious, we can add some sedative agents. Otherwise, if we infiltrate a good amount of local anesthesia, it can be carried out in local anesthesia only. So we are injecting the 2% lignocaine with the 25 gauge of the needle. This is our OT table. Here we can see there is a thin and very small size instruments which we are using in the endoscopic or minimal invasive procedures. And this is a very important component of this table. This is RF probe. This is the AP and the lateral view of the Siam. This is ideal position for the endoscopic needle in the percutaneous endoscopic transforaminal decompression, in which in AP view our placement of our needle or the tip of the needle should not cross the mid-pedicular line, and in lateral view the tip of the needle not cross the posterior longitudinal ligament or PLL. Now we will make small stab incision in the skin or the subcutaneous tissue. Further introduce our working sheath. Patient may feel some discomfort at this time. We can add some sedation if required. Now we can see that our working sheath is reached up to the pedicular line. And now it's very important point to remember in this procedure. When the working sheath reach up to the mid-pedicular line, our bevel will show upward. There is a slight bleeding, and this white structure is the prolapsed disc. So gradually we will remove with the help of forceps, and we can say this white structure is clearly a loose fragment of the disc which is impinging on the nerves. At the 12 o'clock position there is thecal sac. At the 9 o'clock position there is exiting nerves, and at the 6 o'clock there is disc, and at the 3 o'clock there is a vertebral plates. करो pottery. बीस 25 दिन से कितना वजन उठाया था? कितना वजन उठाया था? 120-30 किलो। अच्छा, तो जिम कितने सालों से कर रहे हैं आप? 1 2 3। हाँ जी,
कुशीनगर से सर।
कुशीनगर? हाँ सर। कहाँ पे है?
यूपी में।
यूपी में? हाँ सर। अच्छा, यहाँ कितने सालों से? रेवाड़ी में कहाँ रहते हैं आप?
यही रहता हूँ, किसान वाटिका के पास।
अच्छा अच्छा। क्या किया तुमने? बीटेक?
नहीं, डिप्लोमा किया हूँ अभी। बीटेक कर रहा हूँ
अभी बीटेक कर रहे हो और साथ में जॉब भी कर रहे हो?
हाँ सर।
ये तो अच्छी बात है। तो कितनी सैलरी है तुम्हारी?
17,000।
अच्छा, आप परमानेंट एम्प्लॉय है क्या कंपनी में?
हाँ सर।
ठीक है। फादर क्या करते थे आपके?
कुछ नहीं, तो फार्मिंग करते हैं।
किसान है?
हाँ सर।
अच्छा, this is annular cutter, and we will cut with the help of annulus cutter. There is a posterior annulus of the disc. We will cut it. ठीक लग रहा है? Same. So this was the whole procedure. We adequately removed the prolapsed part of the disc. At the end of procedure, we will aspirate the fluid which was running during the procedure. Cut.